Great. Welcome back. Thank you all for sticking with us. You'll be glad you did. I am pleased now to be able to introduce Dr. Rachel Bender-Ignacio, who is at the University of Washington in Seattle, and she is the medical director there of the COVID-19 Clinical Research Center at the Fred Hutchinson Cancer Research Center. So I'll turn it over to you to give us an update on COVID. Thanks so much for being with us.
Thank you so much, Dr. Cheever. These are my disclosures. So we have 3 learning objectives today. I hope to be able to cover a little bit about the epidemiology of COVID-19 in people with HIV, as well as describe vaccination and other prevention measures for people with HIV. And then lastly, we'll talk about COVID-19 treatment in general, and then specifically where there are differences or other considerations for the population with HIV. So first, to dive into epidemiology. This was some really excited work presented by my colleague Lalo Kashai from UCSD that represents the CNIX multi-site US cohort of people with HIV. So 7 different sites across the United States and comprising about 16,000 people with HIV. And one of the things that really struck us with this work, and one of the big questions was whether COVID incidence was different by whether or not people were immunocompromised or other factors associated with their health or structural issues. And you can see in the bottom graph on the screen that the COVID incidence among people whose CD4 count was greater than 200 or less than 200 was identical. And this was the same whether we chose a cutoff of 350 or really anything else. But what's really striking and not surprising at all, as we talk about disparities and structural barriers faced by people with HIV, is that in the top left, we see that the incidence of COVID among this population tracks overall with what we saw in the general population, or what we're seeing in the general population with Hispanic people with HIV. This is by self-identification. So people who identify as Hispanic having the highest incidence of COVID, followed by people who identify as non-Hispanic Black, and then other race and ethnicity identities and non-Hispanic whites with the lowest COVID incidence. So this, again, mirrors really what we're seeing overall and is important to note. In terms of other structural issues and geographic issues, we're also seeing differences based on where people live. So these are the 7 CNIX sites that participated in this research project, and we see that the incidence was highest in Baltimore, followed by San Diego and Birmingham and Cleveland, with the lowest incidence in Chapel Hill, Boston, and Seattle, again, showing really that the biggest risks to people with HIV is where they live and other structural barriers that they face, and not necessarily their own intrinsic health status. So this was really interesting work, again, presented just 2 days ago at ID Week. Other really important work was done by my colleague Jen Chang at Kaiser Permanente of Southern California, showing that among the Kaiser cohort, they compared people with and without HIV, that they showed that both incidence and hospitalization were 2-fold in people with HIV compared to the general population. And overall, really interestingly, people with HIV in their cohort had fewer comorbidities and were younger than the general population. And another note is that in the Kaiser population, almost their entire population is virologically suppressed. So this may not represent people living with HIV across the country, but still shows increased risk of both COVID incidence and hospitalization. Next, just to continue on talking about the COVID risk versus the general population, some of the, I think, best done and earliest data on this comes from the Western Cape of South Africa, where the public health department there looked at COVID among over 3 million people residing in the Western Cape province, and really showed that there was no difference in risk of COVID-19 diagnosis among people with HIV, but a 2-fold risk of death. And that was partially adjusted for comorbidities. And this here is the forest plot from this really beautiful paper from CID, from their work that showed that age, diabetes, and hypertension, chronic kidney diseases, so among all of the other risk factors that we know for COVID in the general population, we also see that both current or previous diagnosis of tuberculosis and HIV status were strongly associated with death among that population. 2 really interesting recent presentations were made at IAS this summer, just a few months ago, one from the WHO, which looked at 16,000 people from with HIV among a huge population from 24 countries, that showed a modest increase in risk of death and severe or critical illness with people with HIV. But really important to note was that this data was lacking ART status in 60% of the people with HIV, and their results were not stratified by ART viral load or CD4 count. So it's really difficult to know whether it's just being positive or whether it has to do with immunologic status or other medical conditions that were really responsible for this increased risk that they saw. Similarly, among this huge AHA, American Heart Association cohort, looking at cardiovascular disease, they found no significant difference in hospital mortality. This was a US-based cohort and also had no stratification based on CD4 or antiretroviral therapy because those things are very difficult to measure in a non-HIV specific database. And again, we have very little population data that takes into account the incidence versus the general population in a way that we can really look at all of the nuances of structural and individual circumstances that may differ both in healthcare and access to healthcare among people with HIV versus the general population. And some of these that are very important to measure, but are really important to think about. Again, as I mentioned, the structural factors, allostatic load, access to care, substance use, and smoking, which we know are very different among populations with HIV compared to the general population. So we attempt to look at COVID severity among people with HIV. Again, this is not compared in comparison to the general population, but in this really well-curated database from CNIX. And this was presented by my colleague, Adrienne Shapiro at Croy. And what we do note is that when we look at severity as opposed to incidence, we see a much higher risk of hospitalization, critical illness, and death among people with a current CD4 count less than 350 or 200, and also with people who have a CD4 count history that is less than 200, so a nadir or lowest reported CD4 count being less than 200. And then again, this study recapitulated the similar risk that we're seeing in the general population for hypertension, diabetes, age, and BMI, for example. So this still, I think, the work from CNIX helps to address some of the uncertainty around CD4 and viral load thresholds for what we think of increased risk. And much of this, as we talked about, is because the data that looks at risk among people with HIV, for the most part, is missing in some of these bigger databases. So some other cohorts starting from the beginning of the pandemic, especially cohorts in Spain and New York City, suggest a current CD4 of less than 350 as the threshold for increased risk of severity or incidence, others at 200. There's concern for confounding by test date and the SARS-CoV-2 effect on lymphopenia. So for example, that very well done paper from the Western Cape of South Africa, one of the difficult parts to interpret is that they had measured CD4 counts in the index hospitalization for COVID in the majority of their hospitalized patients. And so that makes the interpretation of that data a bit challenging. So from the data from CNIX, we would suggest that a history of CD4 count less than 200 is associated with increased risk of severity, or a current CD4 count less than 350 with a almost 2.7-fold risk of hospitalization, and also a low current CD4-CD8 ratio. So both this history of low CD4 count and current CD4-CD8 ratio are associated with immune exhaustion or immunosenescence. And we think that those are credible reasons why people might have an increased risk of severity despite having a currently reconstituted CD4 count. I also wanted to highlight some of the work that others have done looking at structural disparities, intersecting disparities, and specifically racism on people with HIV during the pandemic. So this is really beautiful work by Greg Millett that was published recently, and it looks at the intersection of the pandemic and the ways that people living with HIV also disproportionately suffer from COVID-19. And again, similar challenges to treating and addressing COVID-19 as facing the End the Epidemic initiative, as well as the fact that there are now competing priorities between addressing COVID-19 and the epidemic. And then there are additional challenges that he brought out that he categorized as unrelated to COVID-19, such as rise of new disparities and new legislation that impairs provision of comprehensive care. So I think this was a really beautiful schematic and way to show what we know is true for HIV and how that impacts SARS-CoV-2 infection as well. I also wanted to talk a little bit about the influence of the pandemic on HIV incidence. So there was really beautiful modeling done in Baltimore that showed that if there was in fact decreased risk behavior because of social distancing, along with change in services, decrease in services, and decrease in new HIV diagnoses, that there would be a decrease in incidence over 1 year. However, if they have that same care interruption without a behavior change, we would actually expect to see incidence increase by almost 11%. And so if there is a combination of fewer partnerships plus care changes, there might be stable incidence. But if we see care interruption with no change in individual behavior, that we will see an increased incidence. So I wanted to move on to talk about COVID prevention in people with HIV. So this is now looking at treating and preventing COVID among individuals. And I think the key take-home point is that vaccines are one of our most important, or the most important tool in this population, just as they are in the general population. So specifically for people with HIV, we want to know what the guidance is. And some of this guidance comes both from the WHO as well as from HIV-MA. I have a link down at the bottom and in the helpful resources page to an FAQ that HIV-MA developed and I helped contribute to, which really suggests that vaccines with any EUA or approved vaccines, so these are the 3 vaccines that are under EUA or full approval in the United States, plus the ones that are endorsed by the WHO globally, are all recommended for people with HIV. There is, I think not stated in the guidelines, but I would say a personal preference and not maybe more than personal preference for the mRNA vaccines. And that's really because in the United States, those are a 2-dose regimen and now a 3-dose regimen for people who are immunocompromised. And we think that people who are likely to have an impaired immune response, really no matter what the vaccine, will do better with a multiple dose regimen. And so simply because the J&J vaccine is currently a single dose, the preference would be for multiple dose regimen. We have heard that that will probably be changing soon with FDA review of the J&J data on the 2-dose vaccine and recommendations for boosters in that population likely coming soon. So what do we know about safety? There have been no increased safety signals or any concerns with either the mRNA or inactivated viral vector vaccine. So that's the J&J vaccine or the AstraZeneca vaccine for people with HIV. And there have been hundreds to thousands of people enrolled in each of those different studies, as well as now thousands, if not millions, of people with HIV who've been vaccinated with these vaccines worldwide and really haven't seen a difference in safety concerns for people with HIV. I'm also showing data on the right from Wolde Meskel and CID, which is looking at vaccine response in people who received mRNA vaccines, people with HIV compared to general population controls, which really shows across all of the different variants and different immune responses that vaccine response rates are similar. And there's also beautiful data published in Lancet that shows similarly for the ChAdOx AstraZeneca vaccine. So we think that these vaccines work similarly. The big caveat is that none of these vaccine studies enrolled people who had a CD4 count less than 200 or were not suppressed on antiretroviral therapy. And so we're really missing what data looks like for people who don't have good immunologic control. And that's part of the reason why the CDC and HIV-MA are endorsing a 3rd dose in the primary series for people with untreated HIV or low CD4 count. And then in contrast to that special population, or this sort of subsegment of people living with HIV who should receive a 3rd dose in their primary regimen, boosters are now also recommended in the general population for people at increased risk by age, medical, or occupational risks after 6 months. And so this would hold true also for people with HIV who are not considered to be in this increased risk category. So I just provided a little bit of the call out here from our recommendations at HIV-MA. And the last important point on this is that, as we know, antiretroviral therapies are life-saving and reduce AIDS and non-AIDS morbidity and mortality for pretty much every cause. And we expect that to be no difference, both for COVID effects, as well as improving response to vaccination. And so improving access to antiretroviral therapy is another really important point, in addition to providing people with a third dose or boosters. I wanted to talk a little bit also about the new guidance for post-exposure prophylaxis. So of the monoclonal antibodies that have an EUA, the Regeneron-CoV or casirivimab and imdevimab product is the only one that is accepted currently for post-exposure prophylaxis. So this is for people who've been exposed but not yet infected with COVID-19. And we would include people that are unvaccinated or that are at risk for not having a good immune response to vaccine in this population. So we would say that the same people who we're calling out as receiving a third dose of their primary series are probably the same population who should receive post-exposure prophylaxis if exposed due to a close contact with COVID. So moving on to treatment for people with HIV. So ambulatory COVID treatment right now in terms of EUA or approved products is really only limited to monoclonal antibodies. And the really important point here is to not differ from the general population guidelines. And so we recommend that people follow NIH and IDSA guidelines in general and consider early treatment for people with HIV with risks of severe outcomes. Again, this is predominantly people who are unvaccinated or people who have untreated, poorly treated or low CD4 count. And that's because we think that these groups, again, have a possible risk of non-response or impaired response to the vaccine. And it's also really important here to think about the non-HIV associated risks with severe COVID outcomes, including age and other medical comorbidities when choosing to offer one of these products. The monoclonals currently available under EUA are casirivimab and imdevimab made by Regeneron, bamlanivimab and endoselimab, which is the Lilly combination, or sotrovimab. And the second option, again, is limited to states in which it is being distributed based on variants. But any of these three products is not considered to have preference or for people with HIV or differ from what's recommended for the general population. And it's really important to know also that there are no approved or authorized treatments for COVID-19 in non-hospitalized patients at the present time, apart from these monoclonals. And it's really important that we as people's primary care physicians and trusted health practitioners discourage unapproved therapies or ART changes unless they're enrolled in a high quality study. So moving on to inpatient management of COVID-19. Again, recommending following the NIH and IDSA guidelines, overall not different for people with HIV. And something that I wanted to call out specifically because it's been a question overall is whether or not people who are considered to be immunosuppressed should not receive IL-6 antagonists or dexamethasone when they're hospitalized. And the answer is that the best data that we have is that they should receive the standard of care and that we shouldn't be concerned about adding immunosuppressants to people who are theoretically immunocompromised. While we don't have specific data on this for people with HIV, we're doing this among people with heme transplants, solid organ transplants, and other types of immunocompromise, and we haven't seen a discouraging safety signal. So just a really strong recommendation to provide the standard of care. And that, just as a quick refresher, means remdesivir for those with early hospitalization, moderate to severe disease, adding dexamethasone plus baricitinib, or an anti-IL-6 for people with an oxygen requirement or ICU status. For the most part, we're no longer using remdesivir in critical illness, thinking that we've passed the antiviral phase of treatment and moving on to the need for immunomodulators. And some particular subpopulations may have indications for antithrombotics as well. And again, this is not different for people with HIV. I wanted to also touch on antiretroviral therapy in COVID-19 for treatment and prevention. I think early on last year, there was a lot of question about benefit of lopinavir, ritonavir, specifically because it was being studied as sort of a broadly acting antiviral. for changing to tenofovir or other antiretrovirals against SARS-CoV-2. At this point in time, we don't have any evidence that any of these treatments, either on their own or as a change in antiretroviral therapies for people who are already on treatment, should change their ART. And so the one, I think, call out here about thinking about a change in ART is really only for people who are receiving a novel antiviral that includes a ritonavir boost, or that is an RNA protease inhibitor. None of these are currently available treatments right now, but there are some studies, specifically the Pfizer investigational drug is a boosted regimen. And so just being cautious about drug-drug interactions or duplication of regimens. For hospitalized patients with COVID-19, we therefore recommend continuing ART without change. And for people who are not currently on ART or ART naive, the best recommendation would be to treat this as if it's an opportunistic infection and initiate ART once a patient is clinically stable prior to hospital discharge, for the best chance at reducing loss to follow-up and making sure that people are offered standard of care therapy while they're in-house. I also wanted to highlight, because this area is moving so quickly, that many COVID-19 studies are inclusive of people with HIV, and this is really due in large part to the advocacy of both AIDS advocacy organizations and many of the HIV researchers who are taking part in COVID research. And so there are several trials specifically that are inclusive of people with HIV. Full listing of investigational trials that are open around the country is available at combatcovid.hhs.gov, both for prevention, treatment, and vaccination. But for treatment, both the Active 2 and Active 6 studies, which are available throughout the country and actually internationally for Active 2, are inclusive of people with HIV. And then we've heard really exciting news about molnupiravir this past weekend, about this study being stopped short for already showing efficacy in treatment. And this Move Ahead study, which is now open across the country, is being tested for post-exposure prophylaxis, and again is inclusive of people with HIV. And because this is not an exhaustive list, I encourage you to go to Combat COVID and check out trials that might be eligible, for which patients might be eligible. So I wanted to also just, with all of this in mind, look at current knowledge gaps, because science is moving so quickly. So I mentioned previously that initial vaccine responses for both the mRNA and adenovirus vectored vaccines are not well known for people who are not on treatment or have a very low CD4 count. So that's a current knowledge gap. And then we also need to look at real world effectiveness of COVID-19 vaccines in people with HIV, and especially with people with untreated or advanced HIV. And this has been very challenging, looking at different variants and geography and different vaccine types in different parts of the globe. But this knowledge is coming soon, I hope. And then again, we also need a better understanding of the real risks of COVID severity in people with HIV who are not on ART and not suppressed. Again, most of these analyses that we've done, including the ones that I've been involved with, are looking at people who are engaged in care, which means for the most part, they have suppressed viral loads or are on ART. And so that's not representative of everybody, especially those with untreated HIV. And also wanting to lastly touch on innovations in HIV care during the COVID-19 pandemic. This was a policy piece from HIVMA that I was really thrilled to participate in with Dr. Agwu and Dr. Armstrong, among several other people. And what we really looked at is that there's been better access to care in ART, because a lot of the red tape that has been removed due to the pandemic. And so a lot of advocacy, both by patients and by physicians, about maintaining some of these improvements. And I think Ryan White has been really involved in this as well. So this is really important that, for example, our patients now have access to 90-day prescriptions, mail-in order increases in telehealth. And we are really, therefore, trying to advocate that these improvements in care not be pulled back when, quote, the public health emergency is over. A lot of this work has really been bolstered by the CARES Fund, which has, again, been advocated really strongly by Ryan White providers. And many innovations are already beginning to disappear. So this is my call to ask all of you to continue to put the pressure on to keep some of these benefits that have been provided to our patient population strong, even as the pandemic kind of the loosening of sort of some of these pandemic rules changes. So here's just a list of helpful resources, some of the things that I've talked about, FAQs from HIVMA and combatcovid.org. So that's it. Thank you so much.
Great, thank you. That was a whirlwind of information in a very short period of time, but super clear. So thanks so much for that. There are a lot of questions. The first question is, should all people with HIV now get a booster shot? Is that the current recommendation? This is
so. Yeah, that's a great question. We are not specifically recommending that all people with HIV get a booster shot, but I think it's really fantastic and important that the CDC gave sort of a broad and permissive recommendation about who should and who may get booster shots. And so one of the things that that can be said is that anybody with HIV could get a booster shot. And it's been specifically recommended for people who have other medical comorbidities, advanced age, or anybody who considers themselves at occupational risk, or also risk based on their living situation, or, for example, living in an institution, homelessness, or some of these other risk factors. So not recommended overtly for everybody, but permissive.
Good. So another question. So can you explain the difference between the third shot, the primary series, and the booster shot?
Great question. This is extremely confusing. So third shots are recommended for people who we don't expect to have a full response to the primary series. So that's people who have untreated HIV or a CD4 count less than 200. This is mostly due to the fact that we don't have great data here. Boosters are for people who haven't had a 3-shot primary series. And so that's meant to maintain immunity in people who already have it, rather than people who we didn't expect to cross the threshold to begin with.
Great. And so for people that have that receive Moderna or J&J, do they get a booster? Like, what happens with them? Can they switch to Pfizer?
Yeah, so right now the answer is no, but the FDA has just published the topics that will be reviewed in their October sessions. And so literally in the next 3 weeks, we should have an answer on boosting for Moderna, boosting in a 2-dose series for J&J, as well as what's called heterologous boosting, which means boosting with a different vaccine than that was received in the primary series. So I think scientifically all of this makes sense, but the FDA will formally weigh in on this in the next 3 weeks.
Okay, so what about giving people their flu vaccine? Can we give it together with the booster for COVID?
Absolutely. The CDC recommended against giving the COVID vaccine with any other vaccine initially. And I think this was just to look at adverse events. But because we now have hundreds of millions of people that received the COVID vaccine, that's been rescinded, and you can actually get them in the same appointment in many cases. And I think that for just getting people to get them, it's strongly recommended.
Okay, so one more question before we move on to something a little bit different. So for people that received only 2 Moderna vaccines, but they're immunosuppressed for whatever reason, HIV or something else, can they get a third Moderna as part of their initial 3?
Yes, so 3-dose initial series is for either mRNA vaccine. The booster right now is only for people who received Pfizer, but again, I think that will be changing in the next couple of weeks.
So what do we know about vaccine hesitancy among people with HIV compared to the general population?
That's a great question. I don't think that it differs all that much from the general population, at least as far as what we've seen. But I do think that we need to think about the fact that brown and Black populations are disproportionately represented among our population with HIV, that we take care of a lot of populations in rural areas. And so I think that a lot of the reasons why people may be concerned about HIV or concerned about, COVID vaccines are generalizable to our population. I would say that I have had a number of my own personal patients, I think early on, especially, who said, I'm really worried about this because of my HIV, and I just wanted to hear it from you. And that was one of the easiest ones to tackle, because I said, yes, this is specifically recommended for people with HIV. And then that took care of a lot of that specific narrow concern, I think.
I think I literally got a call from 80% of my patients before they would get their vaccine. They just wanted to double check.
Just wanted to double check. Yeah.
Right. And so for people that now got the 3 in the series initially, because they're immunosuppressed, do they get a booster at 6 months after the 3rd dose?
They do not currently get a booster. I think that's another area of rapidly changing science. So stay tuned. We're currently not recommending boosters, but that may change over time.
So what do we know about reinfection with COVID, with the coronavirus?
We know that it's certainly happening, especially for people who had a first infection and then didn't get vaccinated. So we know that vaccines are specifically important. And this is a reason that a lot of people would say, I don't need to get vaccinated. I've already had COVID, but we're seeing reinfections in those populations. I don't know that there's any specific data among people with HIV. I think we're still just learning this for the general population, but I would expect that it would be no different, probably, other than for people who may have less of ability to make a strong response to that infection.
And so if someone is coming into care, HIV care again, like been in care before, but they're not currently virally suppressed in terms of their HIV, would you wait until they've been virally suppressed before you start the vaccine series for COVID, or would you start it right away?
I would not. I would vaccinate people right away and then offer them a 3rd dose in the regimen. I think that, in the ideal situation, for example, when we talk about hepatitis B vaccines, that we know that people respond to much better when they're suppressed and their CD4 count is up. I think that's a really great recommendation. But we're in the middle of a pandemic and the community transmission is really high. And so I think shots into arms as soon as possible is the most important, and boost later if we need to.
Great, thank you. And I guess we're still getting some more questions about the 3rd dose in the primary series. Are the outcomes around for people with HIV with COVID, are they equally distributed in terms of adverse outcomes between men and women, or do one gender do worse than the other?
In our data from CNIX, we were seeing higher incidence among women, but not higher severity. And I think what my guess about that is probably increased exposure due to caretaking, working in the healthcare workforce, or more frontline jobs among women. So increased incidence, but not increased in hospitalizations once we adjusted for other factors for HIV and other comorbidity factors.
Should we be testing antibodies in our patients to see what their immune response is?
Right now, we should not, because we don't know what the correct threshold is, whether it's binary positive, negative, or a specific number. And so for any immunocompromised population right now, we're actually not recommending checking antibody responses. Other than, I would say, the one area that this may come into play is soon in hospitalized patients coming in about whether or not they should be receiving monoclonal antibodies in hospitalization, because there's increasing evidence that potentially the monoclonal antibodies, which overall aren't beneficial in hospitalized patients, could be beneficial in people who are antibody negative.
So in terms of vaccination, for someone that had COVID, what kind of series of vaccine would they get?
2-dose series, so same as the general population. We're recommending that people get the standard of care regardless of prior infection history.
And what does breakthrough look like? This is our last question, got about a minute left. What does breakthrough look like for people that are vaccinated with HIV in terms of coming down with COVID?
I don't know that we have specific information on this among people with HIV. Overall, it's been much milder. I have seen at least most of my patients get mild infections. I think for people who never mounted an antibody response, people who are severely immunocompromised, those are people who could end up hospitalized or with severe infections. But for the most part, people should be fairly well protected and have sort of an aborted illness like we're seeing in the general population. Again, that's sort of clinical experience, and we're waiting on data to see if it's significantly different or not.
Great. And with that, we have run out of time. Thanks so much. That was so clear. Thank you so much. And I will turn it over to Mike. Thank you.
Thank you, Dr. Cheever.
Thanks very much, Rachel. That was wonderful.